Thank you for joining us for the second annual Juvenile Justice Roundtable Summit. I am Sharon Wright. I'm today's moderator. I would like to acknowledge our program director, Dr. Karen Kursaki, who is in the back. Thank you. Good morning. Our program specialists, May Chan and Kelly Bitts, who you've met this morning. And then we have some other staff that'll be passing through. So I just want to acknowledge them. We also have Miss Kirsten Barlow with the Department of Corrections. Okay, she'll be back in momentarily. Today's summit will focus on innovative intervention and diversion programs aimed at youth development as solutions for stopping the school-to-prison pipeline. Far too often, youth and young adults with behavioral health needs become involved in the juvenile justice system, and for relatively minor or nonviolent type of offenses. Oftentimes, lack of community-based treatments and services to address specific needs play a role in their admission to the juvenile justice system. So today we will hear from researchers, advocates, providers, youth, and funders on strategies for juvenile justice reform through a rich discussion on research and outcomes pertaining to both state and local initiatives, examples of community-based organizations achieving positive outcomes, as well as funding strategies for youth development emphasizing meaningful opportunities that will impact California's at-risk youth. We will first begin with our keynote presentation, followed by a panel presentation, a video about a young man's journey after lunch, hear from another panel, and then go into a dialogue about strategies for effective change. I would now like to introduce our keynote speaker today, Dr. Ed Cohen. Dr. Cohen received his MSW and PhD in social welfare at the University of Berkeley. He has taught research methods and courses in managed care at both Berkeley and UC Davis, and has provided training to mental health agencies in improving agency performance through the use of data and evaluation. He has over 17 years in senior positions as a clinician, administrator, policy planner, and consultant in both private and public mental health and social service agencies. Dr. Cohen is currently a professor at San Jose State University in the Department of Social Work. Dr. Cohen will give an overview on the juvenile justice reform initiatives landscape through the lenses of data and performance outcomes and trending best practices. Welcome, Dr. Cohen.
Thanks, Sharon. I could use this.
Is that what question?
Yeah, sure.
Okay.
Thanks a lot, Sharon. Yep, we're on. You can hear me? Welcome, everyone. And I want to thank Sharon and the committee organizing this event for inviting me to talk today. It's an honor. And always these types of presentations challenge me to up my game, to get into the latest research. I get involved in projects and research in certain areas, and this is a really good opportunity for me as well. I have about 15 years experience as a psychiatric social worker, but in that course of time, I worked mainly with youth and families. And part of that work was doing crisis intervention in San Francisco County. I worked with a mobile crisis unit, a 24-hour mobile response comprehensive crisis service. I ended up spending many of those evenings at the Youth Guidance Center. And that was my introduction, aside from my work in the psychiatric hospital, where we did treat a lot of kids who had interface with child welfare and juvenile justice. I had a lot of contact with kids who were in Youth Guidance Center. I'm talking about like late 80s, early 90s, so quite a while ago. But I remember one youth in particular who I was asking a whole bunch of questions, doing a mental health assessment at Youth Guidance Center in his room, in his cell. It was a cell, no question. And I was struck with the hopelessness that this young man had. And he asked me directly, right in the middle of this interview, he said, how could things get any worse? And I think those of us that are here today know the answer. The answer is, well, yeah, they can. And that's why we're here to try to intervene so that things don't get worse for that young man and many other young men and women like him. and her. So I hope that this presentation will set us on a course today and put this in perspective. I'm hoping to put the work that you're doing in the context of the latest evidence. When I talked to Sharon about this presentation, she immediately said, first thing, we don't want to just dwell on the problems. And I said, I followed direction, and I said, yeah, okay, that's fine with me. But there are some challenges that we're facing that I want to highlight those challenges in terms of what evidence is supporting them. Only not because I want to rub it in everyone's faces about the challenges. I don't have to do that. You know better than me the challenges that you're facing with these young people. What I want to do is, though that information can lead us to answers and some solutions. I also want to tell you that my attitude is not that I'm the expert, that I know what's best. I don't. In fact, I had a lot of apprehension preparing this because I know I'm speaking to people who work in probation, provide mental health services, work with kids who are in both child welfare, juvenile justice, the toughest of the tough, to place, the hard ones to provide mental health services for, the families who for many reasons beyond everyone's control don't return to the appointment. These are difficult. I understand that. If these were easy problems, you would have solved them already. And that's my attitude. My attitude is I want to present what I know as a researcher so that we can have a dialogue about what you do. The other thing I want you to know is that I understand that there are many innovations that have already been taking place in the last 15, 20 years. Very good ones. Lots of, well, points of light. Takes me back to the first George Bush when he used that. But I mean it in a better way. That there are points of light. There are interventions. There are practices that you're doing that are working. There are initiatives that you're involved with that have had some successes, had some failures, lessons learned. That's the dialogue I hope we have today. I will be here throughout the day, and I want to hear. I'm going to listen with my third ear about that, and I'm inviting you to just come up to me during lunch and during the day to talk about your experiences, and we'll have some time this morning after my main presentation to see if you have any reflections about that. So today, a little bit more about me. So I have become much more interested in juvenile justice research in the past 8 years. I've done surveys with probation departments and mental health departments in conjunction with chief probation officers of California. That information has been published. Some of those briefs are in your packet, but that also has been published in the scholarly literature. I've done analysis of statewide data about the mental health service use and medication prescriptions in detention facilities in the state of California. And most recently, I am working with Santa Clara Juvenile Court in evaluating an expansion of their drug court. So they got a new SAMHSA grant. Maybe some of you are also grantees. And they are expanding their drug court, their famous drug court, to include youth with co-occurring disorders. This is very exciting. And they're having some challenges. It's not a slam dunk, even for Santa Clara County. So it's exciting to work with them, and maybe I'll touch on that a little bit through in my talk. So what I want to do is I want to talk about, I have a clicker, never mind. Arrow, cool, that's the right arrow, okay. So I'm going to talk about some of the challenges we face today. I have a method to my neurosis because there's a point to that. Then I want to talk about the lessons learned from national initiatives, a few of them. It's a little bewildering to go into the internet and look at all the resources available right now. So I tried to call those things that I thought were the most practical and useful for today's work. I want to talk about, in the course of that, I want to talk about some mental health prevalence data that I think will tell us something about the kinds of interventions and practices that we should be doing. And then I will sum up with how this all fits together for the work we're doing today. Closer? Oh, closer? How's that? Is there a volume? Closer. Okay. That's better? All right. I don't have to yell. So much of this presentation is not going to shock and amaze you. This is stuff you've heard before. I'm going to repackage it a little bit. But this is not, I knew coming into this, I was speaking to an audience that has heard much of this stuff in the past. There's a few new pieces of information, but much of it is really just a summary of what you already heard. So I want to talk about some of the challenges you faced. I know you faced them. We know that there's a strong association between mental health problems, substance abuse problems, and the likelihood of getting involved in juvenile justice. We know that there's an overrepresentation in juvenile and adult criminal justice of people of color. We know that. We know that there are challenges in our treatment systems and our service systems in terms of being able to do prevention and early intervention, in terms of treatment once people are in the system, and in terms of continuity of care. We know that there are problems. So basically, the question that I want to address in this talk is really pretty simple. How can we, as a behavioral health initiative, best intervene to reduce the risks and increase the resiliencies of our youth, families, and communities? I think that covers the day. I think that covers everything you're going to hear today. And you'll hear a lot of different stories, success stories, and viewpoints about policy and advocacy that really have to do with this question. So let's start with some facts and figures and numbers. And what I want to do with these figures is imagine following a youth through the juvenile justice system. I want to show the mental health prevalence before, during, and after. What does that look like? Usually when you get presentations of these numbers, it's standalone. A study will focus on one certain thing. I'm trying to show a trajectory here. So I'm going to start with what do we learn from community surveys of youth? Which youth are more at risk than others? Then I'm going to move on to what's the most recent information about the prevalence of mental health problems in juvenile justice settings. And then I want to talk about what happens afterwards. What happens when youth leave? And there's some very good research out now about what happens after their involvement in the juvenile justice system. So there's a fairly new community survey. The community survey basically says that youth with certain mental health disorders have a stronger likelihood to commit crimes. Right? So the survey basically went out, and I think there were a couple thousand youth. Unfortunately, I didn't write down the community. I'll find out and report back to you. But it was a large, scientifically sampled survey of youth in a community household survey. So this is most of these studies about juvenile justice have to do with youth already in the system. Very few studies talk about the need for mental health services in conjunction with the possibility of committing crimes or having committed crimes of the community population. Those disorders that are more prone for youth to get involved in the juvenile justice system are three that won't surprise you: conduct disorder, alcohol disorder, and drug disorder. Okay, that's no surprise, I'm assuming, to anybody in this room. Those disorders compared to any other emotional disorders, and what I'm talking about is a diagnostic protocol that basically runs through a list of symptoms and behaviors that match the DSM-5, and you as a paraprofessional research assistant make a judgment call based on people's answers to those questions. Now, one of the unintended outcomes of the study that I find fascinating is that 88% of the youth who reported having an emotional disorder, and this is an emotional disorder, a recent disorder in the past year, reported they had no involvement with criminal justice and they have never been arrested, and to their best knowledge, they've never committed any crimes. And I think that's important. We forget, those of us who work, in the system forget that there's this whole population of youth out there that may have emotional problems that never get involved with the juvenile justice system. Why is that important? Of course, we here want to prevent youth who do get involved and help them get out. Why is this important? Well, as you go back to your constituencies in your counties, you talk to your boards of supervisors, you talk to the public, I think this is pretty important in general, and it's an advocacy issue about mental health and about what happens in the community. And most people with mental health problems, most adults with mental health problems, are really trying to steer themselves towards normalization. And it's very important to normalize that so many people have had an emotional problem. It's part and parcel of the fabric of our society. And so the fact that 88% of youth in this large survey reported never having committed a crime, I think that's pretty important. And it's important to keep in mind as we talk to our leaders and policy experts. All right, so once the youth gets involved, what does the picture look like? This is the information that's probably most familiar to you. This hasn't changed much. In fact, repeated surveys are consistent. If I went out now and I sampled California youth and I interviewed 5,000 California youth who are currently in the juvenile justice system, either in detention or on probation, I would probably come up with a very similar outcome. That doesn't change much. That 2/3 to 3/4 of our youth in juvenile justice system can be diagnosed with a mental health disorder or a mental health problem. Now, more recently, and I know you've heard this, very large proportion of these youth have experienced trauma. 92%. And this is a very large survey. This was the Chicago Cook County survey, very famous, for one of the first surveys of youth in detention about the prevalence of mental health problems with youth. Same survey, same population, that 92% of them have basically reported that they experienced at least one trauma in their lifetime. And a large percentage of those, well, 11%, but that sounds low to me. I expect it really might be higher, have actually had PTSD symptoms in the past year. Again, I don't think this would surprise you. Those of you who have contact with these kids. And I remember this young man I met. That was the other impression I had. Not only was he hopeless, but he was obviously currently, as we talk, experiencing traumatic reactions. Partly due to being detained, but other recent events. Imagine that combination in somebody, being hopeless and having traumatic response to trauma. Then finally, and this is some of the research I've done, I looked at statewide data on the, every probation department in California is required to report a daily census in their detention facilities. I think once a month they basically take a day as a snapshot and say, this is our census on this day when they're supposed to report it. They send that to the state, but they also report many other things. They report suicide attempts in the past month. They report the current number of youth who have open mental health cases. Anybody hear that phrase before? Open mental health cases? Right. When we surveyed probation departments, we were pretty fascinated by that measure. So we asked about 20 probation departments and mental health counties, mental health agencies. We asked them, well, what does that mean? What does that mean to you? And it meant different things to different counties. So that meant, all right, if we analyze that data, is that really valid? Well, fortunately, maybe each county thought of that data differently, but they were consistently measuring it year to year to year. In fact, these data go back, I don't know, 2004 or earlier. These data are automatically done routinely, right? Some probation officers didn't even know about it back when we interviewed them. And their departments dutifully, routinely collected this information, sent it to the state, and it hadn't been analyzed yet. So we analyzed it, and Jane Pfeiffer from the Chief Probation Officers of California, we analyzed it. I had some help from a statistical expert from Portland State University. And what we found was, what we were interested in was the impact of juvenile realignment. Remember that? 2007, September 2007 was when the policy began. We were interested, was there any shift were there any characteristic changes in local juvenile detention facilities as a result of closing the state facilities? Nobody argued with the reason for closing state facilities. Nobody, it was really the state was actually quite successful at reducing those populations. what's the impact at the local level? And what we found was pretty much right at that point, the trend started increasing of the proportion of youth with mental health problems and use of psychoactive medications at local detention facilities, statewide. So there were very few counties that were any exceptions. It was a statewide phenomenon. So we thought, well, maybe that's just a blip. And maybe you could expect that sort of like market force, you release kids from the state facilities, they go back home to their detention facilities, they get in trouble. So we're going to see a blip, and that's to be expected. In one of our interviews with the probation department, we were asking, well, do you think this is going to have an impact? And they said, well, it already is. We have a youth now who the judge placed, it's not temporary, but placed in the juvenile facility. We thought, well, that sounds interesting. So we wanted to follow up on that. And how much is that happening? And so we kept tracking it. And the data are current as of 2014. And as of last year, I had a student assistant go back in and do another analysis with the updated data. And the trend is still happening. So we're not finished in the work in terms of our detention facilities. Okay, so some other data about what happens to youth who are in the system. Well, so now we know that the proportion of youth with mental health problems is quite high in detention facilities. And what happens is as youth go through the intensity of placement, those youth that go on to be placed in county camps, youth in other states who go on to be placed in state facilities, the proportion of youth with behavioral health disorders increases as youth move through the system. So you get to a state placement or a long-term residential facility, and obviously, and that makes a lot of sense, the proportion of mental health problems will go way up. So as youth progress through the system, the proportion of those youth with serious mental health problems increases as well. Now, a study of in the state of Texas using 100% of placement data, I think over a five-year period, showed that mental health diagnosis was important, but not really the main factor. The main factor was a history of trauma, or the most powerful predictor of severity of placement, trauma. And as you know from the research, trauma is cumulative. The more trauma you experience, the worse off your reaction to it. That's consistently found in the research. Now let's move to after system involvement. I was trying to figure out some fancy graph like I was doing a TED Talk. I just didn't have time. I'm going to probably spend the next 10 years of my life trying to do that just so it looks great. But I was trying to do something like that. Something, that moved on the screen as you, anyway. So what happens after involvement in juvenile justice? There's a handout in your, thank you so much for copying that, from the Pathways to Desistance study. This was a study that was done was based in Pittsburgh, but it involved two separate locations, Maricopa County, Arizona, and Philadelphia, Pennsylvania. Large population areas with large numbers of large detention facilities. And the purpose of the study was, what are the predictors of success or bad outcomes after, as youth progress into adulthood, as they transition out of adolescence? And so one of the questions they asked was, what is the role of having had a mental health problem in that progression to adulthood? This slide is my devil's advocate slide. We all want to say, well, sure, you have mental health problems, you're going to do much worse afterwards. That's partly true. It's a little more complicated than that. Having a mental health disorder in and of itself does not predict recidivism, rearrest, as a young adult. Nor was having a mental health problem, it didn't interact with other risk factors, neighborhood issues, family disorganization, which they measured, underachievement in education. They measured all the factors that we all would know about as risk factors in criminal offending. And having a mental health problem didn't exacerbate those factors. But having a substance abuse problem did. And substance abuse rose to the top in these statistical work that they did. And we're talking about over 1,000 youth in the sample between the two sites. About 1,400 youth between the two sites. Substance abuse alone was a powerful predictor of future involvement in criminal justice. And substance abuse exacerbated all these other risk factors. That's important. Do youth, after they leave the system, do they continue to have mental health problems? I think if I asked you without showing this, you would say, oh, yeah, I think they do. And the answer is the evidence shows that they do. Again, this is back to that Cook County study. So they stayed in there with these youth, and they followed them for 8 years after their first involvement in detention when they were 15 years old. 5 years after leaving the juvenile probation system in Cook County, almost half of them still had a diagnosable mental health problem, as defined by DSM-5 and these research protocols that I mentioned before, right? And now, whenever you hear someone talk about the prevalence of mental health based on the DSM-5, based on national household surveys, you have to take into account that these surveys cover the entire continuum from mild problem to moderate problem to severe problem. So not everybody needs treatment right now today or needs an intervention right now today. It's a continuum. Unfortunately, a large percentage of those fall into the severe category, which is why those of you who are mental health clinicians in the room never feel like your job is done, because there's a large percentage of people that fall into the severe category. Anyway, I'm getting off the subject. So there's continuity of mental health issues after placement in juvenile justice. I want to get back to why that's important for us in a second, like now. So what do we learn from all of this data I've presented so far? There are 3 main points that I want to get across. First of all, anything we do in terms of a statewide initiative or anything you do at the local level to implement something, there has to be a substance abuse component of some sort, right? Now, there are evidence-based practices that don't necessarily have a substance abuse component, like I'm thinking, for example, functional family therapy. You don't bring a drug counselor into the room with the family. It's not part of the intervention. But if the youth does have a substance abuse issue, that's going to be dealt with in one of those phases of the functional family therapy treatment program, right? So in some way, it has to be taken into account that substance abuse is not only a big problem in terms of youth today, but also in terms of a predictor for future problems. And if it's not dealt with in some way, then I think any evidence-based practice you use probably won't work too well in the long run. Second, having been traumatized is an even stronger predictor than having a mental health diagnosis. Now, the two are related, of course. So young people who are traumatized, children who are traumatized, I think the research would agree and consistently show that those children are more likely to be diagnosed with some problem, even if it's PTSD or depression or anxiety. That it goes without saying. But just the diagnosis is not sufficient to be able to predict, statistically anyway, that this young person will go on to commit future crimes. Having a trauma, however, the statistics program has a field day with that youth who have had trauma, and especially cumulative trauma. It pops up as a really important predictor in future offending. And finally, this is my personal pet peeve, I guess. The studies that I did, especially the surveys that we did with the probation departments, one of the main issues that people brought up to us were their concerns about continuity of care. That kids would leave their detention facility with prescriptions, maybe only 2 or 3 days, which is all that they were able to provide at the time. Who knows? But the families and the kids didn't follow up with follow-up appointments. And what we heard was, you know, a lot of self-reflection from probation officers and from mental health clinicians. What are we not doing? What are we not doing to welcome these folks back? So it wasn't, what we didn't hear was simply, well, it's just the families. The families are too disorganized. They're not motivated. Their attitudes are not right for mental health. Their cultural beliefs are getting in the way of being able to accept mental health treatment. All of that may be partly true. But the other question that came up is, what are we not doing as treatment providers and as systems of care to welcome people back into our offices and go to where they're at in the community to make sure that they're getting what they need in terms of mental health care, in terms of concrete needs, in terms of housing stability, and so on. So continuity of care is a big deal, I think. Okay, so I'm going to now refocus on some of the national initiatives. And I know some of you may have come from some counties who participated, so I'm hoping that at the end of my talk, we'll have some time for feedback and comments, and I'm going to invite you, those of you who are from these counties, to, if you were there at the time and know about the work, to comment on lessons that you've learned from your participation in these. And there are 3 main initiatives I want to talk about. The first is called Reclaiming Futures, funded by Robert Wood Johnson Foundation, some money from SAMHSA, and some money from the Federal Department of Justice. Reclaiming Futures is mainly, well, I'll get to that in a minute. The second one is the Healthy Returns Initiative. That was sponsored mainly by the California Endowment. The third one was an initiative that's fairly new called Improving Diversion Policies and Programs for Justice-Involved Youth. And that's funded by SAMHSA and the MacArthur Foundation. So let me talk about those 3 initiatives and what lessons they learned so far from them. Okay, Reclaiming Futures, and I posted the URL for you to look them up when you get a chance. So the purpose is to unite juvenile courts, probation, adolescent substance abuse treatment in the community to reclaim youth. Together they work to improve drug and alcohol treatment and connect teens to positive activities and caring adults. So you take that apart and you have several components. You have drug courts, you have reclaiming, and you have treatment providers. And those are the 3 arms, and that's not a good metaphor, the three legs of the stool, there you go, of the Reclaiming Futures model. There were 2 California counties that participated, Santa Cruz and Ventura. Do we have anybody from Santa Cruz and Ventura here? Oh, too bad. Okay, so they participated. And the lessons that were learned, so in participation means they actually got some funding and they got technical assistance to be able to implement certain things. And the lessons that were learned from that are starting to be published from this program are that there were significant improvements in the alcohol and drug system of care for juvenile justice youth. I don't see the word mental health here, but it's all over the initiative. And I'm presenting it because of basically the model and the lessons learned for us as mental health, behavioral health people. The second lesson, it's not only about drug court implementation. So drug courts preceded this initiative. That wasn't new. However, just setting up a drug court, getting the judge to agree, setting up the calendar, having a drug and alcohol clinician in the courtroom, very good idea, but not alone enough. And what's missing is the multi-agency efforts that are needed to support the judge's decisions, to support the family's decisions, to support the youth's reentry into the community. So that requires a lot of community involvement to maximize youth success, and that was the intent of Reclaiming Futures. So the second initiative I want to talk about is the Healthy Returns Initiative, and that existed from 2005 to 2008. And that one did specifically address mental health issues for juvenile justice. So the purpose is strengthen the capacity of probation departments to improve access to mental health. I'm going to find my place on my notes here. Here we go. To improve access in detention and services for youth in detention facilities and following their release. So that specifically targeted youth who had contact with detention and then left. So there were a few different models of intervention that were tested in the initiative. The first one was mental health screening. A number of locations focused on improving their mental health screening of kids in the juvenile justice system. The second one was multidisciplinary teams. There's that concept again. We heard that from Reclaiming Futures. And the third one was training of staff, cross-training, probation and mental health staff, and so on. Some of the lessons learned from that initiative was they had successes in many areas of service delivery and access. There were evidence-based practices that were implemented in the context of multidisciplinary teams. That's what I want to emphasize. So you can have an evidence-based practice that might work with an individual youth and family, but the needs of this population is so great and expansive in terms of concrete needs that to do an evidence-based practice that focuses on an individual and family only without bringing in other people involved in their lives, it has a better chance of success if you're implementing some cross-disciplinary efforts to do case review, to do planning for discharge, to do planning for service needs, and so on. And finally, some sites continue to struggle with gaps in continuity of care. There's that phrase again. That's a problem that hasn't gone away yet. Okay, so the third initiative is the initiative that's called Improving Diversion Policies and Programs for Youth in the Juvenile Justice System. This is the one that's a federal program, meaning that they mostly provided technical assistance for 8 states, and then this year they're bringing on 4 more states. I have a list in my notes, which if you're interested, I'll tell you what they are. California is not one of them yet. And so just some examples of accomplishments, and there's many more than these, because each state had a lot of individualization of what they wanted to do with this work. The first accomplishment, the development of a school-based diversion, an implementation manual of a school diversion program in Minnesota. I want to come back to that in a minute. The second one was an example of involving law enforcement. So when we talk about pipeline, we're not just talking about pipeline from detention on or pipeline from school on. We're talking about community law enforcement, which is an important part of the pipeline of how youth somehow find themselves involved in the juvenile justice system. So that initiative in Michigan involved training of law enforcement in terms of crisis intervention. In fact, I just heard on the radio an interview with someone in San Francisco County. The police are undergoing crisis intervention training that sounded very similar to this in terms of being able to intervene better with people with a mental health disorder. And then another example, improvement of assessment using the Massachusetts Adolescent Youth Symptom Inventory in implementing it and doing better assessments of mental health problems of kids entering detention. This one caught my attention. And can we toggle to that handout? I think it caught my attention because 2 days ago I had a phone call with Bill Arroyo, Dr. Bill Arroyo, who many of you know. He's with Los Angeles County, the member of the CIBHS Behavioral Juvenile Justice Initiative. He's a member of every single advisory group I can think of. And in some meeting we had on the phone, he mentioned education as a really important site for interviewing. And he didn't have much time to go into it, and I wanted to learn more. And when I talked to him, I realized, oh yeah, this is pretty important. Educational achievement is important, as you'll hear a little later from Mr. Guzman. He would say that educational achievement is a pretty important issue. But this one, called School-based arrest, diversion, decision-making model for students with co-occurring disorders. So what Minnesota did was, at a statewide level, they developed a model protocol for school districts, a draft. And the intent was to pilot it at a school district. And they are just beginning to pilot it at a school district in Hennepin County, which many of you who go back as far as I do in terms of age, you might remember Hennepin County as one of the first counties to implement wraparound way back during the wraparound days. So it's no surprise that Hennepin was interested to pilot this. So let me scroll up and do this. So if you look down, I highlighted some of the interesting things that I saw. So this is basically a flow chart of things that a school should do in the event of a student incident, which could range anywhere from a student threatening and bullying to a student bringing a weapon onto school and using it. So a whole continuum of student incidents. You notice there's two sides of this. The first side is essentially the school response, and the side to the right essentially is law enforcement response. And so it leaves the option for involving law enforcement right away when a student does something extremely serious, like threaten somebody with a weapon or start shooting. So that's an immediate involvement of law enforcement and student, what's the phrase? It used to be students as school security people, but there's another.
Resource officers.
Thank you very much. Resource officers, right. So there's a whole line of law enforcement. And if you scroll down some more, just a little bit more, possible actions. So first of all, is this an incident that really just involves the parent? Do we just need to call the parent, have them come and have a meeting and really figure out there seems to be a problem? Or is it more serious that requires a school case conference? And if you read the manual, the school case conference is not just the principal or the assistant principal, the teacher, and or several teachers, and maybe the social worker. The parent is involved as well. Or, and the outcome of that might be some of these other possible actions, and let's see what some of them are. Screen and assess for co-occurring disorders, screen and assess for trauma, exposure, and symptoms, and connected behavior support team. So I'm going to let that sink in for a second. This is a document for schools. This is not a document for health clinics, or school mental health clinics, or county mental health clinics. If you look at that whole flow chart, what you have, what's missing? You don't see the words suspension or expulsion anywhere on there. Now, in these days of risk management and legal issues for schools and their fear of the most extreme types of student incidents, I think this is extraordinary. That's what caught my attention to this. In fact, you read the manual, and the whole point is to minimize suspensions and expulsion. Why is that important? Well, who are the youth who get suspended and expulsed? You can imagine. Youth of color, youth who talk back, youth with behavior problems, and most likely youth with mental health problems and substance use. Those are the kids who get suspended and expelled. I'm not saying a youth should never get suspended. But this is pretty extraordinary, and I think if I had 2 years of funding in my pocket, I think I only have about 5 minutes of funding in my pocket. But if I had 2 years, I would go to Minnesota, and I would talk to Minnesota. I would see how's that implementation going. I would talk to teachers. I would talk to students. What's the student experience? Did this actually happen? Is this really what's happening? I'd talk to parents. I wouldn't go in the summer because it's too many mosquitoes. I think they also had a really harsh winter, so maybe I'll just make some phone calls. But anyway, I would talk to Minnesota to see, how is this going? Does this really work? So if I had 2 years of funding, I would say, is this possible here? Could we develop something at the state level to pilot at certain schools or school districts? I think this would be extraordinary. The reason it caught my attention is because think of the ground that this covers. We all know that there's disproportionate minority contact in our facilities. Now it's called problems with equity. That's the phrase these days. This directly affects that. We all know that kids with mental health problems really aren't treated very well in schools. They're going to do an assessment on 100% This means 100% of kids with student incidents. This is not just who the teacher thinks needs an assessment. This would be a procedure that would be in place. It has to do with diverting kids away from arrest. Even when you look down here, what can the county attorney referral do? Decline the charge and send back to intervention, divert, or charge. Maybe there's something that's really a chargeable offense, right? But it basically screens these kids so that the automatic solution isn't expulsion and charge. Okay, so I don't know if you've heard about this program before, but I was like, staying up at night thinking about it and thinking, wow, this is interesting. So let's go back to the slides. Thanks. So in my discussion with Sharon, we also talked, well, can you also cover evidence-based practice? And I thought, well, how many hours do I have? So I decided what instead I would do is give you a resource that I think is probably, for our populations, the best collection of information about evidence-based practices for youth in the community, for youth in detention, for youth on probation, and for youth afterwards and beyond. And I think this is a really good resource, and they did a great job. I was quite impressed with how they collected this information. And if you just click on the mental health tab, and there are a number of areas that they cover: mental health, diversion from probation, school-based services, family therapy types of services, different kinds of interventions. They categorize all these interventions. And there are 20 mental health interventions that sort of floated up in the effective category, which means that there's more than one study that has a strong research design and positive findings. And so they used a standardized way of categorizing all these studies. But they also included descriptions and full reports on all the studies, not just the ones that are the gold standard. All of them that they received get put into the database, so you can look at it and decide for yourself, is this something that would work in my local jurisdiction? And I think that the aim of the collection of the website is to really promote this idea of public health model of prevention. A public health model of prevention focuses on risks and resiliencies. And isn't that just what we want to do? We want to be able to predict which kids' risks are going to get them in trouble, and we want to highlight which resiliencies will get them out of trouble and help us help them. And that's really important. Those of us in the mental health systems of care know very well nowadays that you can't just dwell on someone's problems. It's not going to work. It's just not going to work. You need that client's strengths and resiliencies to create a treatment plan that's going to be effective. I don't think any of us have any argument with that. Right? We have to apply that. We have to do a better job at applying that to the youth in our system. So, last slide, promise. And then I want to open this up to some comments and dialogue. What does all this tell us about, a way forward? In other words, I want to go back to my original question. What do the research findings and lessons learned tell us about how to minimize risks and promote resiliencies at the individual, family, and community levels? And I purposely included all those levels in there because when you're thinking about prevention, it's not just the family, it's the community, it's the neighborhood. There's all sorts of risks and resiliencies available in the community that we have to draw from. So let's first talk about prevention and early intervention, thinking back on all the data that we just went through. So we need a way to assess risks early, right? Just like we've pretty much nailed, I think most of our jurisdictions have nailed the policy and protocols for assessing youth as they come into detention. We need to have a way to assess them early. I don't have the answer right now, but we just need to have it. We need school-based programs, especially for avoiding suspension and juvenile justice involvement. Whatever program we do, we need community and stakeholder involvement. That's the lessons learned from all those 3 initiatives, that you can't just implement some practice internally in your clinic and expect it to work without a way to link that family and that youth up with community resources. And that requires coordination and collaboration. Link our efforts with initiatives to increase equity. Okay, so that was one example, that school example. But we have to find a way to link up with the current initiatives that are underway nationally to prevent this disproportionate minority contact or create more equity. I like the word equity because equity infers that it's a much bigger, more environmental issue than just contact. Sure, we want to avoid disproportionate contact, but contact, we want to avoid the contact to begin with. So that means we have to improve and have more equitable services and access to people in the community. Treatment and support. Evidence-based practices are good, absolutely. I don't mean to minimize the importance of using a practice that's been tested and found to be effective. I want to get back to the trauma-informed. There is a trend now to do more trauma-informed care. In Santa Clara County, where I'm working with the Mental Health Agency and the Child Welfare Agency, Santa Clara County pulled together a cross-agency systems team for children. It was initiated by Child Welfare. And the reason they did it initially was they wanted to merge and look at shared data because they were sharing kids and they wanted to be able to communicate better as agencies. And they wanted to find a way to do that. Well, in the process of that discussion, they found, what do we all have in common? That they wanted to answer that first. What are the things that we all have in common, and what are the outcomes we all want to achieve for our kids? And they all agreed that all of the kids in public health, mental health, drug and alcohol, probation, the courts, first 5, they were all around the table. They all agreed our kids are traumatized. And we're not doing a good job in assessing it, and we're re-traumatizing it. Even something as simple as reassessing trauma. A kid goes through another survey interview. Tell us about the time when you were hit. Tell us about the time you were abused. How many times do you want to talk about that without reliving it? And so there are all kinds of ways that a trauma-informed system of care can avoid re-traumatizing youth. Again, multidisciplinary teams in the context of community integration and collaboration. So I would like to make this a checklist, and as initiatives come up, are we doing that, are we doing that, are we doing that? Pro-social, educational, and youth development strategies, which you're going to hear about much more later today from better experts than me. Mentoring from peers, from caring adults. Increased supports for educational achievement. Educational achievement, how many times can I say that? Very important. I was just talking to a community-based agency person. I work with an international network of agencies that provide services to survivors of torture and refugees, and they treat a lot of kids who are victims of human trafficking. And I asked them, well, what's the main challenge that you're facing? Well, the main challenge is not that we know how to diagnose them. We know what their traumas are. We know what mental health needs they have. We know the barriers to getting them into treatment. Cultural barriers are very important. I lost my train of thought. Too bad, it was a good one. I'll get back to it. I hate when that happens. They know how to do that. What they have trouble with is how to engage them, how to motivate them to take advantage of services, right? That's the tricky part. All kinds of barriers for people to accept treatment. How do you motivate? How do you get someone interested in knowing that the importance of treatment, knowing the importance of formal services, knowing the importance of trusting a professional to get you what you need? That's very difficult, very difficult. And that takes me to the continuity of care issue. When we talk about continuity of care with our populations, how are we doing on time? Okay, almost. Last point. When we talk about continuity of care, that's where I was headed. How do we ensure continuity of care? How do we develop our service systems so that they're welcoming, so that they're important for people? How do we do that? We can't just tell them, you know, you better come back for your medications. It's really important for you. You better come back for your medications or else you're going to, I don't know, your depression is going to spike. These words don't mean a lot. We have to find ways to make our services more welcoming and more enticing so that people come back because they know they want to. And that's the challenge we're facing. And that's no small challenge. This is not easy. This is probably, of all the things I'm talking about, I think this might be the most difficult thing of all. How do we, because there are no shortcuts, there's no easy answer, there's no magic bullet about how to ensure good continuity of care for kids in terms of treatment, medications, in terms of connection with community. There's no easy answer. It's labor intensive and it's expensive, and that's a resource issue. But I think it's possible, but it's not something, I just want to stress how important it is in terms of everything else that we're doing. So I'm going to open this up now to comments and questions. If anybody is here from the counties who had participated in these initiatives, I'd like to hear from your experiences. Or if any of this rings a bell in terms of what you're trying back in your community, I think that would be important to highlight. So don't just feel like you have to ask me questions, you can, but share some information about what you've tried back home that seems to be working or what challenges you face. Should we have it on microphone?
No.
Yeah.
I'm not from the county, but I'm a person that takes medications, and I have a question, what if they want their prescriptions, but their insurance won't cover it?
Let's have her use the microphone. Let's all hear the question.
Okay. I'm not from the county, but I wanted to know, what if you want your prescription, but you can't because your insurance won't cover it?
I'm going to ask the experts here. We'll probably get that question twice a day, if not more. What would you do with a client who...
Because those prescriptions run up to $400 or something.
Yeah. And you...
And that I'm a team member from the PA of Merced.
Okay. And you know that you need them?
Yeah.
Yeah. Okay.
Anybody?
So most pharmaceutical companies have a patient assistance program. If you have medication that you need that isn't covered by your insurance, you can get it paid for up to a year usually through patient assistance program. So it just depends on what pharmaceutical company manufactures the medication you need.
We've tried 4 different ones.
Oh, really?
Yeah, we tried Rite Aid, we tried CVS Pharmacy, we tried everyone in Merced.
You have to do it through the pharmaceutical company that makes the medication, not through pharmacy.
Oh, okay. What's the name of that?
It's called patient assistance program. So whatever manufacturer makes the prescription, usually on their website they have information about patient assistance program.
Thank you.
I have a question about that. So after the year is up, though, if you do qualify for it, can you re-register for that program again?
I believe so.
Okay.
Everybody had a question? No.
She asked, after the years, can you re-register for the program? And the gentleman didn't believe so.
Right.
Thank you.
Now with the Affordable Care Act, though, there may be other options in terms of insurance. A lot more than there used to be 5 years ago for people. Comments, questions about what I presented, or anything else that you want to talk about in terms of our task today? Yes.
I'm from a rural county, and in the last year, we've done several things that have proved early success. And most of what you just talked about is where we went.
Mm-hmm.
Our superintendent of schools invented a position in each of the communities called the Student Activities Coordinator, who actually who is in the schools, and the job consists of listening to kids. And it covers mainly the Tier 2 undesignated kids who are seeing the first signs of trauma, first signs of depression, first signs of complications with their education, I'll say. And the physicians have done wonders from the students' own perspective. They've reported back to their own teachers, to administrators, that where have these people been all our career? Very important position and has been very, very successful.
Did everybody hear? Right. So I did some work with a school program in Hayward some years ago, and the teachers were equally as appreciative of having a mental health intervener or caseworker or whatever you call in the schools to do that problem solving with the teachers. Thank you.
On the handout with the Minnesota model, can you tell us a little bit more about how they define student incident? Because I would imagine there'd be things that are not obvious, quote, incidents where someone could get kicked out of school for it, but it could be absences, or especially for girls who are more likely to hold those traumas in rather than act them out.
So the question was, back to the Minnesota model, can I define what they mean by incidents, since there's a whole continuum from people who are internalizing and not behaving? Yeah. Well, that's a very good question. I know I read part of the manual, and they wanted to cover the entire continuum of incidents. Now, what they probably, the weakness in the manual was they probably didn't really spend time talking about those kids who need to be assessed but aren't acting out, like girls with depression. And so that's a good point. I'm going to go back to the manual and check it out. But you can actually go online to the Reclaiming Futures, no, the Diversion website, and you can actually take a look at the manual and see what they say. They define everything that they put in the flow chart. But that's one of the questions we would ask if we went back to Hennepin County and said, well, how's it going? And are you able to, so you maybe you had some successes in diverting acting out kids from getting into law enforcement, but what about kids who aren't yet acting up and may have some serious mental health problems, and it's affecting their school performance?
I have a question to the gentleman that talked from the rural county. In your program, the people that were hired in the schools, one question is, are they clinical?
Yes.
They are clinical?
They have a clinical background.
Okay. And is there a referral process to behavioral health at all, or any
They have the ability
assessments
to divert or to suggest to both the student, to the administration, and to the parents where they think they can get the best help. And that's the coordination now that we're developing throughout the community. It's working. It's amazing.
And what county are you from?
Loomis,
Okay, I'm from Siskiyou.
way.
Way rural, yeah.
Yes, ma'am.
I'm hoping that at some point during today, we're going to be able to address the bigger umbrella of inequality across board. I appreciate that they're talking about the trauma that the kids go through and all the stages that they have to go through to get in contact with, be it criminal justice or probation, courts, and what have you. But I'm hoping that at some point we're going to address the overall umbrella of inequality, period, because we do know that inequality has led to so many things. I mean, you can talk to a kid today and they'll tell you what happens in my neighborhood, what happens in my family, who's addressing those issues that actually informs the trauma that they go through. So unless we actually talk about the bigger umbrella, this thing here is still going to be here until we really address it from the top down, not from the bottom up.
You know about the new research that's happening now. Actually, they collected data. They're analyzing it. They surveyed African Americans in the United States, both Caribbean Americans and African Americans. And one of the questions, they didn't only just ask them the mental health protocol that I discussed before, but they also asked them questions about their experience of discrimination. Right. Because the theory is that the discrimination is a traumatic issue that will impact people's mental wellness. So the results are coming out now. In fact, they're finding that there's a positive correlation between people's experience of discrimination and their mental functioning. Interesting. So that's just confirming what you're saying in terms of the research. So the question is, what can we do as a behavioral health initiative? And may go back to how do we define risks and resiliencies? We have to have some ways that are culturally sensitive to define risk and resiliencies so that we make sure we read them correctly in people. And that may be a start about how we eventually define interventions to address them, to make them more equitable. It's a big question, and I do hope we get back to it throughout the day.
And will there be any information about the foster care system and where those kids come into all of this? There's going to be a piece.
I don't know if the speakers are going to address it. Do you have a question specifically about that population?
Well, just that it seems like that population also, there's no one looking at what the risks are for that population, especially in communities where it's not common and their needs aren't being addressed.
Well, there are communities that are looking at right now what the trend is the focus on dual status youth. And the reason that it's becoming more of a concern is because of the proportion of foster youth who end up in the criminal justice system. And I think that's where you're headed. Mm-hmm. Right. So there is some effort being put into, but it's really hard to understand. For one thing, many counties and states don't even know who they are, because they're not collecting data in a way that tells you at a glance who is this youth in both systems. And we're trying to address that so at least we know who they are. Then we can answer the question, well, what are the risks and resiliencies that affect foster youth and their interface with criminal justice? Thank you very much for your attention, and I look forward to talking with you throughout the day.